All right, welcome everyone. I'm sure there'll be a few more trickling in, but welcome to the UVA Medical Center Hour. I'm Justin Mutter. I'm director of the Medical Center Hour, which is a program of our Center for Health, Humanities, and Ethics here at UVA. We're delighted to bring you today's event in consultation and cooperation with the Generalist Scholars Program here at UVA. And this is in celebration of National Primary Care Week. Before I introduce our distinguished speaker for today, let me just say a few words, as we often do, about the structure of today's session, since we do have some friends joining us on Zoom. So following the lecture, we'll have time for some Q&A and discussion. For our live audience, please just signal and we will get you a microphone. For our Zoom audience, please put a question in the Q&A tab on the bottom of your Zoom screen, and I will monitor that and relay that to our speaker. During our Q&A time, it'll be my privilege to be joined by McKenna Stidham on stage for the Q&A portion of our hour. She's a second-year medical student in our Generalist Scholars Program for Advanced Primary Care and a previous graduate of University of Florida's Geography and Health program. So welcome, McKenna. We're excited you're with us today as well. For all of our attendees, both live and on Zoom, a reminder that you can claim continuing education credit for your participation today. And please just follow the instructions on the slides at the end of your Zoom session, or for those of you who are here today, that's on the handout that you can receive. So health is primary. That's how runs a well-known advertising campaign from the American Academy of Family Physicians. Health is primary. We might find it odd, perhaps, that we need to advertise primary care. It's one of our enduring and unfortunate paradoxes that there's a litany of barriers to high-quality primary care, which in the United States is as long as the list of major contributions that primary care makes to human health. But the need to emphasize again and again that health is primary is not unique to the US context. In 1978, the World Health Organization, in its Declaration of Alma Ata, found it necessary to claim that primary care is the cornerstone of global efforts to improve healthcare inequalities and to ensure health for all. Yet this bold vision, even then, rapidly dissipated, with many in the global health context adopting an alternative goal of selective primary care and jettisoning at that time the idea of comprehensive primary care. So whether it's in the United States or across the world, we often seem to want to cut short our collective vision in the name of reality. But today we're here to make that vision into reality, not vice versa. One of the great challenges of primary care, and indeed one of its great hopes, emanates from its natural position squarely at the intersection of medicine and public health. Today, as we celebrate primary care and look to its future, we are honored to be guided by a leader whose global expertise from a career working right at this intersection. Dr. Mohammed Ali's many titles and degrees reflect his extraordinary contributions across domains. He is a distinguished professor of global health, co-director of the Emory Global Diabetes Research Center, and vice chair for research in the Department of Family Medicine and Preventive Medicine at Emory University. A global citizen with diverse training in medicine, cardiovascular research, global health, business and management, he has built a portfolio focused on cardiometabolic health, healthcare and preventive services, and translation and implementation science, and almost 15 years of service at Emory. Among his many contributions, we find surveillance and policy research at the CDC, leading synthesis reports for the World Health Organization, World Bank, and National Academy of Medicine, among many others. We're delighted today to have Dr. Ali on our Medical Center Hour stage today, and please join me in welcoming him.
So Justin, thank you for the kind introduction, and hello everyone. After an introduction like that, it can only go downhill. And I will certainly say that my wife often reminds me that you have so many degrees and yet you can't do simple things around the house. So there's always a humbling aspect to it. One of which is that I think primary care in general is a very humbling discipline and a very challenging discipline. Today's talk is really using the example of diabetes to try to dig deeper and try to understand what are the fragmented components of the United States health system writ large and how we think about care delivery. So it's just an example case, but I think for many of you, you can think about the areas you work in or the things you're passionate about. And a lot of this might actually ring true. And my hope is to share some opportunities that those of you who work in primary care or in frontline facing clinical situations might actually take from this to improve how things are going. Just to share at the start, I do have some disclosures. None of what I have talked to these companies about has anything to do with my talk today. So here's what I'd like to try and cover. First, I want to use the example of diabetes to share a concept of population health, how we can think beyond the one-on-one clinical interaction and think about the US population and its health, and use diabetes as an example of what has worked, what promising trends have we seen, what advances in medication might actually lead us to in terms of better health. I want to share a little bit about the reality of fragmentation and a little bit about how we got here in terms of the history, but also how it impacts how we deliver care. And then share some ideas about how we might address this fragmentation, and particularly how we might address lack of consistency, lack of alignment, and lack of continuity, all of which are things that you actually need to address a chronic cardiometabolic condition like diabetes. And then lastly, to share an idea or a couple of ideas from the world of primary care in terms of what we can do in terms of innovation, advocacy, and connectivity. So here we go, the promise of population health. So we'll start with a little primer for those of you who don't know diabetes or don't think about it as much in a day as I do. One can think about the situation or the spectrum of glucose really as a spectrum. It's not just yes or no, not a dichotomy necessarily. And if you think about this slide up here, this diagram, any population is distributed across it. So on average, in most populations, 10 to 15% of people will have clinical diabetes. A good third of them might have what we call pre-diabetes, where they are at high risk in the next 3 to 5 years of developing diabetes if things go along the line that they're going on. And about 50 to 60% of them will have normal glucose levels. And our goal as health professionals, as public health, is really to prevent the far right of your screen, is to prevent people from getting diabetes complications like retinopathy, chronic kidney disease, heart disease, strokes, and amputations, and helping them live as healthily as they can towards their eventual demise. The good news in this little primer is that over the years, we've developed a tremendous evidence base in diabetes. Tons and tons of research, literally half a century of research, showing that if we do all the things we're supposed to do in sort of regular continuous care, things like foot exams and eye exams, better control of risk factors like glucose, blood pressure, cholesterol, stopping people from smoking, optimizing people's functionality, we can actually lower the right end of the spectrum in terms of complications, and quite significantly. For example, good glycemic and blood pressure control will lower heart attacks, strokes by about 10 to 15 percentage points, and will lower chronic kidney disease, retinopathy by about 30 to 40 percentage points. So it's tremendous. And we've used observational studies and all of these trials showing enormous benefits that I just described, and additional meta-analyses to really come up with the idea of diabetes care. We could have metrics that we can look at as a population and see how we're doing. And we were doing quite well there for a while. between 1990 and about 2010. We documented this a few years ago, looking at national data, looking at the sort of the A, B, C, Ds of diabetes care, i.e. A1C, blood pressure, cholesterol, and do not smoke. And you can see here the distribution, for example, of A1C shifting over time with a greater proportion of people coming in under A1Cs of 8, and on average, those achieving the target of an A1C of 7, increasing over time by about 8 percentage points. We saw the same thing for blood pressure. We saw the same thing for cholesterol, and not much change, unfortunately, in that 12 to 15-year period on smoking in people with diabetes in the United States. The other huge improvements we saw was that on account of these massive risk factor changes, or what we consider massive because they're population level, we actually saw declines in acute myocardial infarction rates, declines in strokes. We saw declines in amputations, sort of more numbing of end-stage kidney disease, and declines in admissions for hyperglycemia, all across the United States up to about 2010. And mortality has also reduced. This is a slightly confusing slide, but it's age-specific mortality that you see here. And you'll notice, first of all, that yes, people with diabetes have higher mortality rates than people without diabetes, even in our most recent data. But the good news is that if you go from the blue line in both to the red line to the black line, which is over time, you'll notice those rates are coming down in mortality. So people with diabetes are living longer, which is a win. And to boot, in the last decade, we've had just amazing advances in medications, a couple of which I'm going to show you now, one of which is the GLP-1 receptor agonists, which have tremendous benefits on glycemic control. You can see here, this is a trial of semaglutide, and it shows that, you use this medication compared to placebo, which is the gray up here. Semaglutide in any dose is associated with much better, greater reduction in glycemia, and that can be maintained for 2 years. And similarly, those people lose a tremendous amount of weight, about 5 to 6 kilograms, and can keep it off for about 2 years, assuming they continue to take the medication. What's much more important than this finding is actually that it actually has cardiovascular benefits. Sorry about the very messy slide, but this is from a meta-analysis of all the GLP-1 receptor agonist trials. And you can see here on average, they were done in people who are about 60 to 65 years of age, who have fairly high BMIs, anywhere from 30 to 35. And you'll notice here, people who starting A1Cs varied anywhere from 7 to sort of 9, and they've had diabetes for 9 to 12 years on average, and a lot of them had existing cardiovascular disease, which is a big deal because we're obviously worried about their vascular health. And the again, very messy slide shows you small-ish reduction, but about a 14% relative risk reduction in heart attacks, strokes, and death. And then importantly, about a 12% benefit in all deaths. And very, very importantly, given the muted effect that we saw in end-stage renal disease in our national data, here, there was actually a 21% benefit in progression of chronic kidney disease across all of these trials. So that is really starting to give us some signal and some hope that we can really start to make a dent in chronic kidney disease in the coming decades. And if that wasn't enough, there's this other class of medications also released in the last decade, what are called the SGLT2 inhibitors. We're here in another meta-analysis that's messy, that includes about 60,000 participants across all these trials, on average, again, 60 to 65-year-old participants who've had high A1Cs for a while, who've had diabetes for anywhere from 5 to 13 years. And you'll notice here improvements in non-fatal stroke, non-fatal MI, and death, more in people who have established disease in the green you'll see there, and less so in people who don't have established disease. But look at these massive improvements in hospitalization for heart failure. We're talking about 30 to 40% benefits And again, kidney disease, huge benefits, somewhere again in the 30 to 40% relative risk reductions in composite kidney outcomes. So there's tremendous opportunity here to improve the population with diabetes, to improve their health, and to really change the trajectory of costs in the United States. That said, we have an unfortunate situation where we are an incredibly fragmented and have an incredibly fragmented approach to how we think about health at the population level. And I would argue that even at the individual level, it gets very challenging. Much of this is rooted in our history. So I am not a historian, but from what I understand, around the time of the Civil War and since then, we have always operated on a fee-for-service basis for how healthcare was delivered. In other words, people pay to get services. And yes, around the turn of the 20th century, that changed. From my understanding, third-party insurance became a big thing, largely to expand access for individuals, to get more individuals the ability, for those who didn't have cash in their pocket to pay, to be able to go to a doctor and to get care, or to go to a nurse practitioner or whoever that might be. The unfortunate thing is that fee-for-service still dominated. So now, yes, it was a third party paying, whether it was Medicare and the government, or whether it was Medicaid, or whether it was an employer-based insurer that you pay for, they are still paying the healthcare professional on a fee-for-service basis, which unfortunately has led to the idea that care is transactional, less relationship-based. It's very much, I come and get care. It is a service. I pay in some way for that care. And it's led, unfortunately, the more we've had insurance companies in the mix, to what is considered a major problem in health economics, and that is moral hazard, which is that somebody else is paying. Why don't we get them to pay more? As noted in this cartoon, is that we've gotten to this transactional level of finding things to do for people so that we can bill for it, which is kind of sad. And so in a recent commentary and overview paper in Health Affairs that I had the pleasure of writing, we thought a lot about fragmentation, and we looked around and we tried to find a good definition for fragmentation, and it was actually really hard. So we used this working definition that L. Haug has posed in the past, which is the idea that fragmentation is where it's characterized essentially by silos and heterogeneity. And in particular, this idea that the silos exist, especially where there are lack of unified goals and policies, the incentives are malaligned, information is discontinuous across different stakeholders in the healthcare spectrum. And essentially what that results in is lack of coordination and highly variable quality of care that patients get. And it deviates from what we really want them to get, which is what the evidence base shows works. And unfortunately, people just get variation in what they get. And we end up with lack of consistency in what people are eligible for and what gets covered. We have this incredible lack of goal alignment. And as I mentioned, sort of lack of continuity, all of which are critical for patients with diabetes who essentially need very regular, continuous patient-centered care. So what ends up happening is our diverse population of people, even those within the same socioeconomic group or same demographic group, because of the variation in how we deliver care, in their access to care through employer-based insurance or Medicaid, and how Medicaid differs by state, and then potentially eventual care through Medicare, there's just huge variation in how those people have access. Just it goes up and down the spectrum, unclear who's going to get what access. And sometimes, even when they have the same access, we have vast heterogeneity in people's outcomes. And you won't be surprised to hear that part of that at the clinical interface is affecting how clinicians try to get things covered for their patients. I'm sure none of you have had the delightful task of being behind an electronic medical record screen, trying to get that slightly more expensive but more effective medication for your patient. And between you and the pharmacist who's receiving it on the other end, there's a big black box. and it's unclear whether this is going to get covered, if ever, and what it's going to take to get it covered and what it's going to take to get it done. So we have just tremendous gaps in eligibility and lack of consistency in eligibility for any care. We then have a lack of alignment. And if you'll forgive me, I'm going to use an example from an area that I don't know very well, which is college football. And I would have used Emory, but we just are so bad at college football that it's not even a great example. So apologies in advance that I used your institution, UVA, as my example. But think of it a little bit like this, and I'm going to ask for poetic license on this, so work with me here. Think of the NCAA or the league, whatever league you can think of. You can use the NFL if you like, as payers who set the policies, and essentially as payers, especially if they're private payers, they want more people, right? They want more people to sign up because that's more premiums. And so the NCAA, in a similar way, wants more TV rights, more audiences to show up for TVs and for games. And so they set the policies with the notion of more people, more patients, less paying out means more profit for us. So they don't necessarily want to pay for a whole lot of services, but they want more people to show up. And people you can think of as crowds, and you can think of them as essentially the patients in our system, populations. The intermediary in terms of where people go for their football, for the thing that they need, is health systems. And here we're going to use UVA as an example. So they might come to the UVA health system, and the UVA team is a great metaphor for that, where hopefully people are showing up to games. You have big crowds every week, and these are our patient populations who largely want to see their team doing really well, right? And they want care that is delivered in a way that is most efficient, makes them happy on a regular basis, like a game of football does, hopefully. And usually what patients want, I think, is they want their quarterback, who hopefully is that guy in the middle, who can see the whole field, who I would argue is the primary care doc, who can see the whole field, who can set the plate and navigate through the crazy system because it's a mess. But he or she also needs the offensive line to block. He or she also needs terrific wide receivers. Let's call them our specialists within healthcare, who do special things that we need, and we need to hand off the ball at certain times and not at others. And so we have this system, which is sort of metaphorically speaking in college football, it's working. But think about when this goes dysfunctional. And think about all the different stakeholders I just mentioned who might have slightly ulterior motives. So let's say our specialists, sorry for any specialists in the room, might want more in terms of making pro teams next year. They might want to be seen more. So they might want to carry the ball way more. In our system, fee-for-service encourages that tremendously, because the more they carry the ball, the more they get paid, right? Similarly, you could argue that the coaches on the sideline, academics like me, are going around saying, this is the play you should set because this is actually going to improve care. And then it's a question of, what if it was malaligned enough that primary care also got paid more for holding the ball, for doing more procedures? And so we have malalignment in a tremendous way here. And I don't even get me started on the difference between what the system will do in terms of how many wide receivers they pay for versus how many offensive linesmen they pay for. Because in primary care, we would argue we need the linesmen. We need people to help with care coordination. We need more staff, we need scribes, whatever it is you want to use as a metaphor, to make that time with the patient more efficient, to actually spend our time on the things that matter, not on the other rigorous tasks that we don't want to be doing. And so this malalignment generally, again, poetic license, is leading to dysfunctional care, unfortunately, in my view. And then third, we have this lack of continuity, which is that across states, we have information discontinuity. Increasingly across different stakeholders in healthcare, everybody has their piece of the information pie. Pharmacies have relationships and have your data and my data. Healthcare systems do. States have different registries, for example, for opioids, for vaccines, and for other things, but those don't cross over states very easily. And so we have these silos of information which are not shared because they're proprietary. And the person I feel that loses out the most is the patient. I'm sure many of you have experienced, and I remember this very vividly, meeting a lady who had a headache, who went through a number of scans in our emergency room at Emory Healthcare, only to find out 2 hours later that actually the night before she had been at a different system that was 1 mile away that used an entirely different electronic medical record and had the same CT scans and same things that we did for her. So we just replicated everything, we duplicated everything, we wasted all those resources because of siloed information. How that has played out for diabetes is unfortunately poorly. Over time, we've had humongous growth in diabetes. You can see here data from 2004 to 2019 at the county level in the United States, and more blue means higher prevalence. You can see that more and more counties have become darker and darker blue over time. In the last decade alone, there has been a 42% increase in diabetes, in absolute numbers of people with diabetes, where now we have 37 million people with diabetes affected in the United States. Since 2010, which was with the previous data that I showed you, which is the yellow line, we had those improvements early on in the data I showed you. And since then, we've had stagnation, essentially flattening and even reducing all of the ABCDs of diabetes care. We also have inflation, unfortunately, of our care in that, sorry about the messy slide, but if you look at the red, people with diabetes versus those without diabetes, and then the difference over time, sorry about that, where I've marked in blue, you'll notice that we have larger outpatient costs for people with diabetes, and a lot of our costs are being driven by outpatient medications especially. And so we just have inflation in what we're doing, but we're not actually improving the care metrics as I showed you. And if that wasn't convincing enough, all of the complications improvements I showed you earlier, which were up to about 2010, where we had 11% annual percent change reductions prior to 2010. Following that, we have had an uptick in amputations in the United States with people with diabetes in the range of about 5 percentage points per year increases. If that wasn't enough, we are incredibly fragmented in how we have data at the state level. Here are some data that we ran using HCUP data, which is the Healthcare Utilization Project data, which are essentially state registries on claims. And they tell us about inpatient use, emergency department use, and preventable admissions and preventable complications. And we had data from 2008, 11, 14, and 17. And you'll see here, let me orient you to this real quick. This is time on the x-axis over here. This points to the Affordable Care Act and the 2015 ICD-9 to ICD-10 conversion that we went through in terms of how we code. So that could have had an impact on this. And you'll notice the black line is the national average of emergency department use for non-Hispanic whites. So that's the national average. And then the blue is the 9 states that I've picked here, the average of those 9. And the gray is each state line. You'll notice here a couple of things. Number one, yes, after 2014-15, there was a small uptick in emergency department use for diabetes-specific emergency department use in non-Hispanic whites in the United States. You'll also notice that across those 9 states, there's actually just a very small amount of dispersion. So they were all very similar for that population subgroup. However, it's not the same when you look, it is a little bit the same for people who are Hispanic, but really 3 times higher the state average for non-Hispanic Blacks and look at this tremendous dispersion across the states we have here, not huge surprise to many people here that the states that were doing the worst there were Kentucky, Florida, and Arizona. Similarly, you could argue, okay, race, ethnicity, not great. What about what really matters? Third-party payments. And so when we look at private insurers, again, here's the national average. Those that are privately insured, you'll see have lower rates of emergency department use on average and very little dispersion. Contrast that with those that are uninsured, gets a little bit closer to the national average, but those that have Medicare and Medicaid, which are our publicly funded programs, much higher. And for Medicaid, unfortunately, huge dispersion in use of emergency departments. You might ask, okay, and is that all the same for different race ethnic groups? So we took that specific Medicaid group, this one here earlier, and we looked specifically within that. And this paper is still under review, so please keep confidential. But you'll notice again, differences in race ethnicity, even within Medicaid. So people who have the same insurance by state, there is still dispersion in how they're accessing care. This may have to do with trust in the healthcare system. This may have to do with other things in terms of access to primary care, where people are essentially using the emergency department for their basic diabetes needs, which is quite unfortunate. You wouldn't be surprised to see that the same pattern exists for inpatient admissions, albeit that here inpatient admissions for diabetes have tended to stay very flat over time and even small declines. I think the payers, the leagues, are thinking about ways they can lower that as much as possible because inpatient admissions cost a whole lot. We also risk, I think, further stagflation as we think about this because all those new fancy medications I told you about are being used by a fraction of the population with diabetes, approximately 6 to 7% of them so far. Admittedly, they were only released here in about 2013-14. So we still have to see some better uptick. But at the moment, care is still dominated by the use of insulin and metformin for people with diabetes. And if the disparities I showed you earlier weren't enough, even commercially insured people, this database of 1 million commercially insured people, there was a 17% less likelihood of people who are non-Hispanic Black to get any of those newer medications than people who are non-Hispanic white. So there's something definitely different about how we're delivering our care. So how do we address this? This seems all very overwhelming. Part of it is rooted in how we've done market-based delivery of healthcare. And it's very hard to make the argument that we should just flip that on its head and have entire companies vanish, entire leagues vanish. That's not going to happen anytime soon. So instead of trying to stop the waves, let's learn to surf. And so in this paper, we proposed 3 broad ideas to address each of those 3 big issues. For the lack of consistency issue, we proposed this idea that if you thought about what is high value versus low value, and there's a lot of research in this space, right? It's much more high value to control the risk factors early to help people with their lifestyle than it is to spend on their amputation or to spend for multiple days of a hyperglycemia admission. So if you can identify what the high value services are and mandate that they are fully covered for everyone, maybe we'll get more consistency in the United States. And we can do this. I mean, there are data to show that even in a simple condition like diabetes, things like doctor visits, medications should be covered for everyone, rather than have, at the moment, our fragmented approach, which results in many of these higher cost things like inpatient admissions or ER use to be paid for instead, because currently the fee-for-service system drives a lot of those. The fee-for-service system essentially, as you can see here, drives the idea that there's payment for every single service. So you can imagine that skews us towards systems and programs that really focus on high-cost treatments like amputations, rather than high-value treatments like stopping smoking. And so there is this notion that maybe if we align the incentives of different stakeholders and made sure everybody was playing for the same purpose for the patient, and we use things like bundled payments, which is that you get paid for the whole person and everything that you do for them, it then becomes your interest to save the money. It then becomes your interest to not let them be admitted to the hospital, to not let them need dialysis, to not let them get so far down the road that it's terrible. And so bundle payments is an idea that's not new. It's been going on a while. The health policy wonks out of you probably have heard about this a lot and are going to ask me a lot of tough questions. Warning, I don't have all the answers. But because it's been going on a long time, there's actually a range of how you can think about bundled payments and capitation. On the far end here, category 4 is literally capitation, whereas, in other words, for each person, you get paid a single amount as a whole health system. Whatever you do to care for them, if you end up with amputations, you end up with coronary bypass grafts, that's on you. The system has given you its amount. We're not there yet, but we're getting there. We're probably about here right now, where most health systems and Medicare and most big payers and leagues are saying, you know what? We'll give you standard amounts, not per patient, for time. If you noticed in 2021, most of you who practice in care and code, you can now do time-based coding. That was to try to get us away from this idea of constantly up-coding and giving a problem list that was 30 things. Now you can just say, look, I spent 30 minutes counseling this person about their diet. I'm going to bill for that, and I'm going to get paid a set amount for that. And that's a step towards getting us where I think Medicare and the big payers really want us, which is over here. Lastly, I think there's this question of interoperability. And I think this is a challenging one because, again, everybody owns different components of data. And my argument is the patient should own their own data. And they should be able to carry it in one cloud, probably on their phone, across states, across employers, wherever they want to go, and it should be accessible, almost like your Amazon account is, right? You can go to Seattle right now and order things on Amazon if you have a Prime account. You can go to Southeastern Florida and do the same thing. So we really need to get towards those sort of models and incentivizing this. Now, will anybody really, will Epic or others spend on this? Probably not. So this is where the federal government really needs to step in, I suspect, because ultimately the group of people that eventually inherits all people with diabetes is Medicare when they turn 65 or when they end up on dialysis. So really, it is in the federal government's interest to do this. It's just a question of if we can get them to get there. So where does primary care come into all of this? You're like, wow, he's been waxing lyrical about policy stuff that he knows very little about. Where does primary care come into it? And I would argue that, over the years, I think primary care clinicians have been more on the silent end of advocacy. And where primary care has had advocates, it's that every group, the specialists have them, the primary care docs have them, every group has their own advocates who largely are advocating more for barriers to entry. In other words, how do we protect ourselves? How do we keep our own fire hydrant secure? As opposed to this idea of how do we keep the patient secure and how do we keep our populations healthy? And I think if we switch the conversation and really start to talk about capitation being good for all systems, that should pay itself back by providing more offensive linesmen, if you will. The second is that even if you don't believe you need to be an advocate, it's happening to you anyway. So that brings me to point number 2, which is it's in your own interest in primary care to think about care delivery innovations. And I'm going to show you a couple of them within the next 4 minutes. So just to say, it's complicated to deliver high value care because behavior change is not easy. Patients themselves might have motivation challenges. They might have short-termism, if you will, in that they want results now, and everything we do takes time. Clinicians might have a difficult time being accountable to their patients, but we can help them with that. The other thing they might have difficulty with is clinical inertia and always being up to date with evidence. Again, we can help them with that. And third, I think systems are hard, right? Because of the fragmentation, because of access barriers, the burnout that clinicians face in trying to help their patients can actually be detrimental and can make it very hard for them to want to care about whole populations. We did a couple of trials in this space, not here, unfortunately, in India, but interesting because it's also a country with fee-for-service care. And we showed that you might be able to overcome this even in that context. And we use the idea that because there are multiple sets of barriers, that you need multiple interventions. So we have this idea of multi-component interventions where we went in to support patients with their behavior change by using care navigators, people who have social work degrees, clinical nutrition degrees, who helped us bridge the gap between the time that clinicians have and the time that people spend at home and at work doing the things that we need them to do to live healthier. We helped clinicians because we realized inertia was going to be hard for them, and we built decision support tools to prompt them to do the right thing. And we used dashboards to help clinics not let patients fall through the cracks and not let fragmentation drop them out. So here are some examples. We essentially used a very simple tool that we developed on an app, on a tablet that was given to clinicians and the care navigators. And you can see here that for every new case, in this case, Olivia Austin, who is made up, who's 52 and has had diabetes for about 8 years, there's a tab for each of the things we want covered. So her glucose, her blood pressure, her LDL, and her depression status. And the system would prompt what we should do. And we built in some behavioral economics into it, which is that if they accepted, it went on. But if they said, no, I decline to accept the prompt, then they had to give a reason. And wouldn't you know it, clinicians hate giving reasons. So they just accepted what we wanted them to do most of the time. And we essentially got things to work. We use these dashboards where the clinician could basically look at individual patients like Beyonce over here and see what her major problems were, versus also potentially looking at the whole clinic and trying to understand what's the distribution of people who fall into this glucose, and this glucose thing, so that we can really work on these people and make a list and get them back into clinic and do better population health. And you wouldn't be surprised that we did a trial initially in 1,200 people with terrible A1Cs and blood pressures and cholesterols. They started at A1Cs of almost 10 because it was a pragmatic trial, and the patients in both arms saw the same clinicians. We actually had enhanced care for the control group. So the control group also had some benefit, which is this line over here, the solid line. But those in the intervention arm had an even better reduction in A1C, which persisted for 2.5 years. We had benefits in blood pressure, both systolic and diastolic, and larger benefits in cholesterol reduction. So that was one trial. Then we said, could we do this in even harder patients? Let's set the bar higher. Let's find the people who are depressed, people who had PHQ-9 scores of 10 or above, so moderate to severe depression. We showed the same thing. You can get them to have improvements in care, which is the yellow group over here, that were larger in the intervention arm than in the control arm. And specifically, their depression scores were far, far, far better. So all that to say, I hope what you've taken away from today is the idea that diabetes is one example of a multifactorial growing problem where population health has worked in the past. But the more we go along and the more fragmented we get, the more we allow different groups of the market-based system to basically go in for their own benefits, we get greater inconsistencies, we get greater malalignment of goals that do not benefit our patients, and we get lack of continuity of information for those people. I think it's possible to address all of those. Many of our OECD country colleagues have done this in Scandinavia and other places. So nationally, we can do it. As I showed you with some data, I think locally, any of you can do it if there's a little bit of investment from our systems. And I think in general, we have to do it not just because of our patients and because of population health, but because we need to reduce costs. Healthcare is a $4 trillion industry in this country, 1/10 of which goes to one condition, diabetes. We can reduce those if we just do the right things and we keep them out of hospitals and we keep them in better care. And needless to say, for any of you who are health professionals, I think it would be great not to have to do prior auths, right? Because I think that would help our well-being and our mental health. So all that to say, I hope this has been interesting to all of you. Many thanks to our grander village of people who contribute to our work and to many of the funders who have supported what I do. Thanks for your attention.
Thank you so much. There's a lot to discuss and unpack. And again, please feel free to signal. We'll bring you a microphone if you're in the live audience, and then people on Zoom, feel free to enter a question into the Q&A tab. I know my colleague McKenna has a question that she would like to ask, so go for it.
Yes, thank you so much, Dr. Ali. I just wanted to echo Dr. Mutter's. Thank you for coming, sharing with us today. And I'm sure myself, and as well as many of the students listening here today, we find it very encouraging to see this type of call for change being in the discourse. If you don't mind, I had the two questions on your approach to addressing fragmentation. So in the beginning of your framework, it seems to be calling for two interrelated necessary changes, one being on the side of providers, collaborating to have more preventative care, and on the side of third-party payers, supporting this preventative effort with the reimbursement. Do you feel that these two changes can happen simultaneously, or where does this cycle of change begin?
Yeah, terrific question. So I think they can happen simultaneously. I mean, I don't know enough about how. I will say health policy in general, when it changes, is a somewhat blunt instrument in that it takes both time and can have very small effects on big populations. So when you think about reimbursement and a move towards something like capitation, where you're trying to align the incentives of different groups, I think it's sort of a natural progression for those different groups to figure out how they should function in it. So I do think it will be simultaneous, but I will say that in general, as I said, it's going to be a blunt effect at the population, but that at some specific subgroups, possibly what we often see is lower socioeconomic groups tend to have bigger benefits because their baseline is already much poorer. So getting them back to a median is actually quite effective. So you can actually get greater population health equity from big population changes like that, and big policy changes, I should say.
Any other questions? We have one from Zoom, which I'll pass on. The participant says, you seem to use diabetes as synonymous for type 2 diabetes. How do you propose solutions? How do the proposed solutions and problems face change when you instead tackle type 1 diabetes? And namely, how do younger diagnosis ages that tend to be predominant with type 1 affect what the sort of things that you were talking about?
Yeah, terrific question. So type 1, as you know, is a completely different clinical phenotype, which is that people are born with essentially an islet cell deficiency and don't have enough insulin. So it's a very different paradigm to be thinking about, how you help people with type 1, because clearly it is not their fault. They were born with that. That said, what is very similar about type 1 and type 2 diabetes is that poor control is still associated with high emergency department use, high use of inpatient facilities because of hyperglycemia, hypoglycemia, and also a very fast progression to complications, all of which in trials have shown that if you control glucose, blood pressure, cholesterol, and not smoking, that you can actually lower that and improve life expectancy and actually almost normalize life expectancy. So the evidence is the same, the challenges are the same, except that sometimes people with type 1 diabetes have a harder time getting control. What is also very much the same is that we have incredible technologies nowadays. We have continuous glucose monitors, insulin pumps. We just have fancier tools for them. Access is as similarly challenging as it is for people with type 2. And so I think I would argue that exactly the same policies will work if there is a minimum package of services that are high value that can work for people to keep them out of the ER, to keep their glucose control really good. We should do it. We should have it because, again, especially for them, there was nothing they did that caused that. And by having that minimum set, and in fact, I would say it's highly valuable to do that.
Yeah. I want to ask, oh, sorry, question. Go ahead.
Thank you so much. This is a fantastic talk. I am not a primary care doctor. I'm an endocrinologist, and but I think we struggle with all of the same things that you outlined. I appreciated your the idea of the navigator and trying to figure out that target population that you're where you're going to potentially have the greatest intervention. But I think we, like primary care doctors, are not nearly enough for the populations that we have to serve. And in fact, I serve as essentially primary care doctor for many of my patients because they can't find primary care doctors. So I wonder, I mean, there's no solution other than grand solutions here, but how, I guess I struggle with how do you displace care for one group of patients to be able to maximize care for another? How do we prioritize?
Yeah, I mean, that's a tremendous question. Thank you for it. I think there's a couple of ways to think about that problem. One is the very macro, right? And that's that, I don't know where some people here sit on the side of this. And so, totally fine if you totally disagree with me, but you're right. The supply of healthcare professionals and people who deliver care is small. If people feel like this is not difficult care, which I don't think it is, we should actually consider expanding our pool of allied health professionals, people who are physician assistants and nurse practitioners that essentially don't just see the patient for the clinician, for the doctor, but see their own panel so that we get a greater supply to deliver care. And then if we complement that with ideas like Tom Bodenheimer has, Tom, for those of you who don't know, is a professor of primary care at UCSF and is a big thinker in terms of how we do the chronic care model. And his argument is we should then pay for care navigation and care coordination such that it frees up the clinician's time. And especially a clinician like yourself, who is an endocrinologist, a specialist, I would want you seeing the most brittle and most challenging people that I don't know how to handle in primary care, that definitely the physician assistant does not know how to handle in a primary care practice, and really have specialist services be focused on the more mentally challenging cases that you can apply everything you've learned in your specialty training to focus on. And allow care navigation and other population health tools like those dashboards to really help us figure out who goes to specialty care, who can be managed safely by me, and who can be managed safely by somebody who has even less experience than me. Hope that answers your question. Operationally very hard to do, I will admit.
Yeah, so I think when it comes to talking about payment and reimbursement with primary care, I feel like it always comes up that primary care physicians are paid wholly less than our specialty colleagues who see our patients where prevention didn't quite work. So in the kind of model where capitation occurs, how would the incentives be pushed so that the piece of the pie of that capitation doesn't just solely go to your specialist, but instead goes towards encouraging prevention and hiring more primary care docs and that kind of thing?
Yeah, I mean, it's very indirect, it's very subtle, but the idea really is that if you can keep the patient and let's say you're getting paid $100 per year for that patient. If you can keep them from getting an amputation or on dialysis, everything you save, everything you don't spend, you save. So you get to keep more of that 100 for yourself. So the system as a large group that is being paid directly by the payer might actually start to think about what investments they might make in something like primary care, because it then keeps them out of specialty care or potentially more expensive procedures. And so really it's a question of, now if I invest $10 out of that 10% into primary care, maybe I can make my primary care docs more efficient and keep them or allow them to spend more time with their patients and really optimize that care in a way where we can keep the population of patients healthier. Healthier means less expenditure.
So, I want to sort of take a spin off of some of the questions that have been asked and go back to this idea of subpopulations and siloing. And I want to come back to the behavioral economics aspect of this, because there's the alternative to that model would be, we're already over behavioral economics as clinicians, right? We have so many things within the electronic medical record that are popping up and we're closing, et cetera. And interestingly, that sort of connects with earlier in your talk about, I was struck by the dates in which we really did well, which happened to be not perfectly aligned in terms of a time course, but pretty closely aligned in a time course with before the true advent of massive commercialization of certain types of medicine in the United States, and including quality metrics. So are there ways that we can, in your model, take the best of the behavioral and economics work while also trying to mitigate some of the risks of that in terms of provider fatigue and really being able to work through that work and the EHR especially?
Yeah, I mean, that's a really tough question. I will say also that I designed that trial when I wasn't an active clinician and didn't realize how much of a burden it would be. Now that I am back in practice, I'm like, wow, that would have been a real pain in the backside. But yeah, we also did that in the context of a place where they didn't have as many electronic pings at them. And so I suspect the sort of short answer to what you're saying is yes, I think it is very challenging to do that in today's context where we have so much going on in a healthcare setting. But I would also make the argument that I think we're getting to the level of technology that personalization should be more possible by the tools that we have, such that technologies should be able to be geared towards certain prompts coming up for people with diabetes, certain prompts for attention, certain prompts for etc. And so I wonder whether that's one way where we can almost segment how many pings you get at you so that we can optimize the behavioral economic benefit. But again, I say this as somebody who's never coded, who's never actually done anything technology focused before.
Thank you. Well, unfortunately, we're out of time, but I want to thank Dr. Ali for joining us today. Thank you for all being here, as well as our friends on Zoom. And this is just a really important exploration in the future of primary care, and we hope you'll continue to have conversations amongst yourselves. Please join us next week here in the Penn Hall Auditorium and on Zoom. We will host Professor Wendy Klein, who's a leading scholar in the history of women's health in the United States, and the Dima Selye Chair in the History of Medicine at Purdue University. Professor Klein will engage us in a critical analysis of medicine, gender, and power, focusing on a history of the pelvic exam in clinical practice and in policy discussions concerning preventive health. So we hope you'll join us next week, and thank you all again.